Hello, everyone. It's a Sunday, and we are back with something very, very interesting. Today, we are dealing with correction of class 3 skeletal malocclusion in a facial asymmetry case treated with the Damon appliance and buccal shell bone screws. It's biomechanics and clinical perspectives. These type of topics nowadays calls for a lot of interest among the audience, and therefore, this case is probably going to be an eye-opener for all of you. There is a patient who visited to us at 21 years of age with a class 3 facial profile. He had facial asymmetry, which is his chief complaint. He had a mandibular shift to the right with spacing in the upper and the lower anterior teeth. It was a class 3 malocclusion with mandibular prognathism. This patient visited multiple orthodontists who all told him a surgical option. And I also felt after clinical examination that this was a surgical case. But since he never wanted to go ahead with the surgery, we opted for a non-surgical option. And I told the patient that we would try to get it done non-surgically with buccal shell bone screws. But if it does not work, then we probably have to go with surgery. The gums and the bone configuration need to favor the tooth movement, which is happening over a span of time. Now, when we looked into the case records, we found that, yes, there was a skeletal asymmetry. A functional component was there too to the skeletal asymmetry. The patient also had severe midline discrepancy where the mandible lower arch was shifted as compared to the facial midline by 7 millimeters. So there was a facial asymmetry and spacing in the upper and the lower anterior teeth. When we looked at a 45-degree view, we understood that it's a class 3 skeletal base, mostly a mandibular prognathism case. He had proclination of the upper and the lower anterior teeth, which is to compensate for the skeletal malocclusion that is there for this patient. He had a concave facial profile and quite a lot of chin prominence. The intraoral views also showed that it's a class 1 molar relationship on the right-hand side, but it was basically due to the mandible shifting to the right, following an occlusal interference, which was there in 1-3 and 4-3 region. So there was a functional component to this asymmetry also. On the left-hand side, it was a full class 3 relationship with negative overjet. There was spacing in the upper and the lower anterior teeth, and there was a severe midline shift to the right by 7 millimeters. So the mandible was shifted to the right by 7 millimeters, following a skeletal as well as a functional asymmetry. When you looked at the occlusal view, there was proclination of the upper and the lower anterior teeth and subsequent spacing associated with it. Now, there are third molars present in the mandibular arch also. Now, we told the patient that if we want to try it non-surgically, we have to extract the third molar. Otherwise, it's impossible to displace the lower arch and give you a proper result. He opted for the third molar extraction at a later date. When we looked into the radiograph, the PA view, and the Grumman analysis, we came to a conclusion that it's a combination of skeletal as well as functional asymmetry. We noted that the mandible was shifted to the right significantly, probably due to a functional component which came from an occlusal interference in the 1-3 and the 4-3 region, and a skeletal component also. The cephalometry showed it's a class 3 skeletal base, and there was proclination of the upper and the lower anterior teeth. That is basically a natural compensation which happens in a class 3 malocclusion. The tracing showed similar issues, and when we superimposed on the facial profile, it showed that the skeletal region was the main cause of a class 3 facial profile and the concavity of the profile that we are noting in this patient. When we did a cephalometric parameter reading, we noted that the A and B was -7 degrees, which means that this patient has severe class 3 malocclusion and calls for a surgical intervention. There was proclination of the upper and the lower anterior teeth. There were negative overjet, and this negative overjet is supposed to be more, but because of the proclination of the upper anterior teeth, the negative overjet showed initially less. So the the conclusion out of the lateral cephalometric parameters was, it's a class 3 skeletal base, it's a vertical growth pattern, it's proclined upper incisors, normally inclined lower incisors, and a concave facial profile. So this is basically a case of skeletal class 3 vertical malocclusion with facial asymmetry. When we looked into the radiograph, we came to a conclusion that both the upper and the lower third molars were present, and the lower third molars mandatorily needs to be extracted if we at all plan to do a lower distalization, because the amount of distalization that is possible in the lower arch is the distance from the distal most aspect of the second molar to the anterior border of the ramus. Now, if the third molar is present in between, virtually your anatomic parameters does not allow you to distalize. So in all distalization cases, in the mandibular arch, it is advisable to remove the third molars. So you need to knock off the third molars to get a proper distalization done. Now, what is the anatomic boundaries which we have for distalization in most cases in the mandibular arch? If you go through this angle of inflection note in the GIOS interview by Dr. Junji Sugawara, we came to a conclusion that the biologic boundaries in the mandibular arch or mandibular distalization is basically the lingual cortical plate. And the angle that it forms with the anterior border of the ramus is called as the angle of inflection. So you need to really knock off the third molars if you want to have adequate space for the lower arch distalization. Now, one of the foremost articles put forth for buccal shelf screws for lower arch distalization was by Chris Chang, Lin, and Roberts. And how different is these bone screws different from the regular microimplant that we use? Now, the regular microimplants that we use are made of titanium alloys. And as you can see, the elastic modulus, yield strength, and the tensile strength of most of them are lesser than stainless steel. Buccal shelf screws are basically made with stainless steel. They have smooth mushroom-like head. They have four-way rectangular holes. They are mostly 12 to 14 millimeters in length. They have a double neck design. They have a collar which is of longer length because you want to put them mostly in the movable mucosa. They're made of stainless steel, which has greater modulus of elasticity, basically greater strength than the titanium alloy mini implants that we use regularly. And they have sharp cutting edge because they are usually placed in D1 quality bone, which is mostly the infrazygomatic crest and the buccal shelf area of the mandible. So the treatment plan in this case was to distalize the mandibular arch, to close up spaces in the upper and the lower arch initially, which would give us a lot of negative overjet, and then followed by distalization by placement of bone screws. Now, the placements of bone screws in most cases, if it is done by an experienced hand, is quite easy because there is no or probably no anatomic landmarks closely associated with the buccal shelf region. Neither there is any chance of getting trismus because the buccal shelf region does not have any the muscular attachment. Neither there is a chance of an inferior alveolar nerve damage because it is way away from the buccal shelf region. Since this patient did not have any consent for orthognathic surgery, we thought this to be the only option to treat such complicated cases. We used buccal shelf bone screws of 12 into 2 millimeters. That's 12 millimeters in length and 2 millimeters in diameter. And you can follow the biomechanics given by Almeida on extra alveolar mini implants. That a wonderful article that came out in Dental Press Journal of Orthodontics as to how you need to manipulate the four systems, which we are going to discuss in detail in this lecture also. Now, how is, we know there's a difference between the mini implant that we are using and the stainless steel bone screws in the previous slide. But there is a biomechanical perspective difference also, because all these mini screws, that is the mini implant, which are made of titanium alloys, are placed interdentally. That is in the alveolar bone in between the two roots. But all these bone screws are placed away from the roots in the infrazygomatic crest, and they are not placed interdentally. They are also placed much higher up with respect to the occlusal plane. Now that gives a great advantage because there is no vertical forces associated with force systems from buccal shelf and intrazygomatic screws. While there are vertical force vector problems associated with a mini implant because they are virtually placed below the occlusal plane. And the point of application of the force has vertical components to it. Sometimes they are beneficial, sometimes they need to be controlled so that we get adequate tooth movement. So whenever you are dealing with these two form of screws, you also have to understand that not only is there a technical issue, that is a material difference, but there is a difference in the biomechanics that we use in both the cases. So what is the option in this case? We want to extract the 3/8 and the 4/8. We want to close spaces in the upper and the lower arch by retraction. Now that would be decompensation, which would mean that we would get a lot of negative overjet. And then we want to do a full arch distalization of the lower arch for improving the class 3 facial pattern. Now, the appliance of choice in such complicated cases for me is the Damon appliance because they are a passive self-ligation system. And when we are using multiple force systems, it is better that we use a self-ligation appliance, which has, basically better sliding efficacy than the normal MBT ligate system. And the oral hygiene plays a very important part because you have multiple force vectors and multiple E-chains and coil spring being placed from the screws, and you really want the patient to maintain good oral hygiene. So a self-ligation appliance is of benefit. The other advantage of the Damon appliance in this case is that we are not planning to extract in the upper arch as a process of decompensation. So therefore, we can choose a low torque bracket in the upper arch so that we get more upright upper anterior teeth. So you have a +2 degree torque in these cases of low torque Damon appliance. So therefore, which would mean that I would have a more upright central incisors and anterior teeth as compared to a +22 degree torque in the normal MBT system. In such cases, in the normal MBT, we need to extract basically for that purpose, because the torque, if we have a +22 degree torque, the problem is that we would have proclined incisors in the upper arch, which means that we will also have less amount of negative overjet to work with, and henceforth we will have less improvement in the facial profile. But if you have a 2 degree torque in the upper arch, which is a low torque as compared as we have that option in the Damon appliance, basically what advantage we would have is that we can upright the incisors more in the upper arch. So we would have greater amount of negative overjet, and therefore greater amount of distalization is possible in the lower arch. Therefore, we would have better improvement in profile. So a variable torque option in the Damon appliance and any other variable torque appliance is a great advantage in this case. Also, we also need to understand that when we are doing a significant amount of distalization in the lower arch, another problem that comes is that you get a lot of tipping in the lower arch. When you have a lot of tipping in the lower arch, the lower anterior teeth might undergo a lot of gingival recession because you are moving the tooth by significant amount in the mandibular cortical bone. If you invert the brackets of a standard torque bracket of the Damon appliance, you will get a +6 degree torque. A +6 degree torque will give you an advantage in keeping the roots within the trough of the cortical bone in these cases, so that whenever you're doing full arch distalization, you really don't get any amount of side effects, something like a gingival recession or thinning of the attached gingiva in the lower arch, which might compromise the lower dentition at a later date, which you really don't want. So whenever we are planning to do such complicated cases, it is required that you plan out your appliance system way before you have started the case, so that they are able to substantiate the efficacy, and you need to have all the armamentariums in hand in order to treat such complicated cases. So what is the sequencing of the wire that we plan to use? And this is the sequence of the wire with respect to the days that it was used. So we in the upper arch, it was basically 01690 to start with, and then for 60 days is 018 SS, and followed by 60 days of 1925 90, and the working archwire in the upper arch for retraction and closure of spaces. That which we kept for about 440 days was a 1925 stainless steel. That is our working archware. And then we settled it out with a very light night eye archware. In the lower arch, the movements are much more significant, and hence we started with alignment and we closed the space, and then the distalization. Then we had further alignment with 1925 night eye, and we had a significant amount of time where active lower arch distalization was done with the 1925 SS screws. So now we have the posted archwire in this case. So the treatment the progress in this case is something like this. So we had the upper and the lower archwares in place. Once the upper and lower archwares were in place, we started closing the spaces in the upper and the lower arch, and therefore you see that the negative spaces have started to develop. We also started noting that the mandible is starting to reposition itself in the right place. You also have to note that we had inverted the brackets in the lower arch in order to get a positive torque in the lower anteriors, because we plan to retract them, and we really don't want to tip the lower incisors significantly, which would have a problem with the bony architecture and the thinning of the lower gingival architecture also. So basically it's decompensation which is happening in this case. Once we close up the upper and the lower space and we overcome the natural compensation which has happened, you would find that we get about minus 5 to 6 mm of negative overjet in this case. So this is after decompensation. As we see that the post alignment and decompensation, you would note that there is a partial correction of asymmetry post decompensation. If you see the second photograph, you would understand, as compared to the first photograph on the left hand side, that the mandible has slightly shifted to the left. That's basically because you are able to correct the functional asymmetry that was associated. The skeletal asymmetry needn't be corrected or cannot be corrected with the basically bone screws. We can only correct the dental asymmetry. We also got a more concave profile at the end of the decompensation phase. So that is after decompensation, in which we got about minus 5 mm of negative overjet. That's significant amount of negative overjet that is there after closure of the spaces in the upper and the lower arch. So that is the amount of natural compensation that has happened for this case. Nature is a great healer. It always tries to establish function of the upper and the lower anteriors. Now, if you are to dislice, we have to negate the natural compensation and then correct the true the dental and skeletal problem that is associated with it. Now, full arch retraction of the lower arch is then required by about 7 millimeters, because now we have a minus 5 mm of negative overjet. So we again took a lateral ceph at this position to check out the amount of correction that is required. We had Buccal screws in place at that point of time. So the composite analysis and the tracing and all showed that the negative overjet has worsened after the natural compensation was taken care of, and the concavity of the profile has also worsened. Now, the skeletal parameters at this point of time would show that you now have an ANB of minus 9 degrees. So we started with a minus 7 degree ANB. Now we have a minus 9 degree ANB. We have a width of minus 10 mm. We also have to notice that the upper incisors were retracted because we had starting about 43 degrees. Now we have about 38. The lower incisors were kept more upright. That's because we had plus 6 degree torque by inverting the lower standard torque brackets. And IMPA was 83. That's not favorable because now we want about 95, 98 to do that much amount of distalization. But still, we want to try it and check out how it works out before we plan for a surgery if that doesn't work out. So what is the position at this point of time? It is class 3 skeletal base. We have a vertical growth pattern. We have proclined upper incisors, which had improved now because we had retracted the upper incisors. Normal inclination of the lower incisors. We now have increased negative overjet. because we have overcome the natural compensation, we have a more concave profile now. Now, it's still skeletal class 3 vertical malocclusion. That's another issue. Okay, vertical control is required in such cases because class 3 vertical cases are probably one of the toughest cases to be treated. And we have a bit of facial asymmetry remaining even after the correction of the functional asymmetry. Now, we plan to place 12 millimeter into 2 millimeter buccal shelf screws. Now you would find that the two screws on the right and the left side are not placed in the same place. That's a common query that I come to know. You have to understand that on the right and the left side, the buccal shelves are not same in each patient. Also, there is an ethnic difference between the amount of buccal shelf present in an oriented population and an Indian population. After years of experience, we have noted that the amount of buccal shelf present in the Indian population is slightly lesser. Sometimes the bone is so deep, the buccal shelf area is so deep with respect to the occlusal plane that if you place it so deep, first of all, they get covered up with the soft tissue, the implant. And then we have a canting of the occlusal plane because at one point of time, okay, the screw on the right hand side might be placed in the buccal shelf, which is highly placed, and on the left hand side, it might be lowerly placed. So you have to check out the position of the screw while you're placing, depending on the amount of bone that you have in each patient. So if you find that the buccal shelf area is too deep, or you are not able to find the buccal shelf area in an Indian population, you can obviously place it much more distally in the external oblique ridge. So that's exactly what we did on the right hand side, because we did not find good amount of bone in the buccal shelf region on the right hand side. We placed the screw much more distally. On the left hand side, everything was all fine. We placed it lateral to the second molar, which is the ideal place for placing the buccal shelf screw. The external oblique ridge might be a great area if the buccal shelf area is not prominently available in your patient. So that also has great amount of bone. So external oblique ridge placement for patients with no or deeply placed buccal shelf is one of the things that a take-home message which you can take. So that's the difference of position of the screw in one patient. So if you don't find the buccal shelf, then you can opt for other places to place the buccal shelf screw. Now, there are lots of articles to say where ideally it needs to be placed. So one of the most prominent article comes from Nucera. And they found out that the mandibular buccal shelf is best placed lateral to the second molar region. Now, what happens is that whether you find a lot of articles, but it comes down to patients which you are treating. And what we have found over the years is that every patient is different. So whenever you are planning to place a buccal shelf screw, either you take a CBCT, and if you are well experienced, you can actually palpate the area of the buccal shelf region to check out where you actually need to place the screw. If you have buccal shelf lateral to the second molars on both the sides and they are pretty good, great, you are lucky. If you don't have it, I just described you what you can do. You can go more distally and place it in the external oblique ridge. You might have a problem in the Indian population while placing a buccal shelf because for all the Oriental populations that we treat, we have found that the buccal shelf area is shallow and pretty wide. That's a great advantage of people from the Oriental origin or orthodontists from the Oriental origin when they're treating cases with buccal shelf screws. But we can also do it. We just have to orient it according to the natural changes. Now, the other, a lot of articles are there whether a horizontal growth pattern or a vertical growth pattern patient might have different areas of buccal shelf. Yes, if you go through this article by Vargas, you will find that vertical growth pattern patients have a more deeply placed or less amount of width in the buccal shelf region, while a horizontal growth pattern patient will have a better width of buccal shelf. Now, a lot of articles are there, but it all comes down to clinical experience when you're treating patients. There is the one more article which comes out in the Korean Journal of Orthodontics, which talks about the different craniofacial patterns, and they found out that there is not much of a difference between the horizontal and the vertical growers when it comes down to the thickness of the buccal shelf region. So I would tell you as clinician, it is more to do with clinical experience and more to do with the patient and the origin of the patient that you are treating. So go ahead and do it. Okay, we are giving you clinical tips so that if you're in trouble, you know where to place. There is one more, a couple of articles on ethnicity. The one by Sebastian Baumgartel and Tarek, which talks about that how much amount of buccal shelf region is available in the white patients. And they found out that the best area is again the distal buccal area of the second molar. There is one from India, by Dr. Neeraj Kolje, and he noted that again the same thing, the good amount of buccal shelf lateral to the CJ of the second molar region. But there is no comparative study of different ethnicity with respect to buccal shelf. But out of clinical experience, I'm telling you that we treat both types of population, and we are blessed about that. And we found out that yes. Or when it comes down to Oriental origin patient, because I treat a lot of people from the Northeast, who are mostly of Oriental origin, they have great buccal shelves. They have shallow. While if I treat someone from the Far East or someone from Central India, I find that the buccal shelf area is very deep. That could be a problem, and therefore, and this patient was from Jharkhand. Okay, so you have to understand that this patient did not have great buccal shelves. So we found out a different place for placing it. So I think this is a good enough tip for you to understand when you are treating, when you're placing buccal shelf next time in an Indian patient. So yes, we went ahead and you can see that on the left hand side, the buccal shelf is placed lateral to the second molar. On the right hand side, it is placed much more distally. If you feel that you are placing it much more distally, and then you will have overlap of the gingiva, as you can see in this case, what we usually do is that we tie a hook to the buccal shelf and allow the buccal shelf to go inside the gums till the end of the treatment, and then we can laser it out. And if you are hanging a hook outside the buccal shelf, what happens is that whenever you're changing the E-chain for the span of time, you will never have a issue of fondling with the gingiva, and you will have less amount of irritation to the patient also. That's a lot of requirement. You can also see that we have placed a lot of blue bite because we want to open up the bite, provide a clearance for the lower arch to get disclosed, and help in development of the positive overjet. So that's in progress. So our working archwire is a 1925 stainless steel posted archwire. And that's the area in which we actually place the buccal shelf for disclosure. So the net effect of this buccal shelf screws and the amount of force that we are giving is basically disclosure and a clockwise rotation of the mandibular arch. Now, this clockwise rotation is probably favorable because it helps in a bit of extrusion of the anterior segment, and which helps in deepening of the bite. And as you would know that if you have a slightly deeper bite at the end of treatment of a class 3 skeletal pattern, the chances of relapse is far less. Okay, so if you have an open bite at the end of a correction of a class 3, then there is chances of relapse. When you have a little bit of a deep bite, it's the upper anteriors which help to prevent the relapse of the class 3 in the lower anteriors. So that's a great advantage of buccal shelf screws too, with respect to the force system. So when it comes to the treatment progress, okay, let us check out on how the biomechanics works once we place the screw. And it's a 1925 stainless steel archwire. Please don't use thinner archwires, because you will have no control over movement, because you are giving a force of maybe 300 to 350 grams of force on each side for dislocating the whole mandibular arch. That's the amount of force required. So if you have a thinner archwire, you will have flexing of the archwire. I feel the 2125 is probably too much. You might say that it will not have any torque slop. It will, you will have a snugly fitted wire, but sometimes it becomes a problem to manipulate those wires. Okay, take them and clean up the area and put it back. Sometimes your brackets might also pop out. So I prefer a 1925 stainless steel archwire. So that's dislocation that would happen, and there you will get a bit of clockwise rotation of the lower anteriors. So that's good, because that would help in deepening of the bite by 2. So you will have something like this. But once the force component you give, it will have a clockwise rotation, which also means that you will get a bit of tipping in the anteriors. But your lower inverted brackets, that is plus 6 degree torque, which you have after inverting the standard bracket, would prevent uncontrolled tipping from happening. I won't say that tipping won't happen, but if you invert the brackets, you will get less amount of tipping, and the lesser amount of tipping and bodily dislocation that you get, the better it is for you, because then your gingival architecture and bony architecture in the lower arch would be much more favorable. So that's then what you do. Now, as you see that we have closed off spaces in the upper and the lower arch, and then we are trying to dislice one screw on the left hand side placed in the buccal region, one screw on the right hand side placed in the external oblique ridge, just because we didn't have enough buccal on the right hand side. So we are doing full arch dislication. At the end of the treatment, we find that we have a class 1 molar on the right hand side. Remember, we had bilateral class 3 after the decompensation phase. Now we have a class 1. We have a class 1 on the left hand side. We started with a full class 3. We have a midline which is perfectly on. You also would know that the lower incisors are slightly slanted towards the left of the patient. That's because there is a skeletal asymmetry associated with the patient also, not only a functional asymmetry. And last, whenever you are treating such complicated cases, the aspirations of the patient tend to increase. And he kept telling me that if at all I am able to get a good midline, it would be great. So we gave crossbite elastic, and we told that we cannot change the position of the mandible because it's a skeletal problem. We have to go ahead with the surgery, but we can tilt the incisors a bit on the left and match with the upper midline. He was happy with it at the end of the day. We corrected the proclination of the upper and the lower anterior teeth. We also corrected the spacing and the negative overjet. So as you find that we have closure of spaces by retraction of the upper arch, and we have closure of spaces by retraction of the lower arch. And that's full arch dislocation in the possible by about 7 millimeters on either side. If you see the present status, the midline is almost on. The skeletal midline is slightly shifted about 2 millimeters to the right hand side. That's because of the skeletal problem. The smile aesthetics is excellent at the end of the day. That's great. We got a good profile also. Smile aesthetics is grossly improved. We have a orthogonal facial profile now. In fact, the upper lip is slightly ahead of the lower lip. That's a great thing when you're finishing a class 3 problem. The chin prominence is also reduced. Whenever we check out on the OPG, we find that there is no root resorption in the molar area, which is pretty common. If at all you're giving heavy load of forces, we didn't. We extracted the third molars, we told you initially, and we disliced it. You would find that the left side dislocation is a bit more because we started the full class 3. On the right hand dislocation is a bit less because we started more or less with a super class 1. So and the upper third molars were not extracted initially because they have nothing to do with the lower arch dislocation. But if they are extruded and you feel that there is a problem with the occlusal plane, they need to be extracted. However, we told this patient to prophylactically extract the third molars 1/8 and 2/8 at a later date. We would also tell you that if you find that while the lower arch dislocation, the upper third molars are interfering with the dislocation process, you need to knock them out. But it was not in this case. So the cephalometry shows that now we have a positive overjet we remember how it was after the decompensation phase. Now there is a positive overjet. We would also see that the lower incisor lie in good bony contour architecture. And that's great. That's very promising to be seen. That's what we are looking at. The tracing showed that the convexity of profile has definitely improved. We have got good dislocation of the mandibular arch, and we had corrected the inclination of the upper and the lower anterior teeth. So what is the final cephalometric parameter suggest? It suggests that the presented A and B is still class 3-ish. We had corrected that the growth pattern is still a bit vertical, but the proclination of upper incisors is improved. We had retroclined the lower incisors. The lower incisors were retroclined, but since we had inverted the bracket in the lower arch, the retroclination was far lesser. And we corrected the overjet. That's great. We corrected the convex facial profile of the patient. And about 70–80% of the skeletal asymmetry that he initially had, because he never wanted to go for surgery. So that was a camouflage of class 3 done. So that's how we started. It's left-hand side, we had a full class 3. Then we decompensated it by closure of spaces in the upper and the lower arch. And then we extracted the third molars and disguised it with buccal shell screws. And we got a class 1 molar relationship at the end of the treatment. So the midline started with a single unit shift, which is about 7 millimeters of shift that was there in the midline. So we disguised more on the left hand side and a bit less on the right hand side. We got a perfect midline at the end of the ring. That was the amount of midline shift that was there. The 7 millimeters, 8 millimeters of midline shift, and now we have a good midline. So that's the comparison. Okay, we see that the skeletal asymmetry has partially improved. Functional asymmetry is completely gone. That's improvement of asymmetry. Then we have asymmetric smile. You can see the mandible where it is in smile. Okay, it angles to the right hand side. Okay, but at the end of the treatment, we find that the midlines are far better. So improvement of asymmetry. Smile aesthetics is definitely improved, and we can see there is the retraction of the upper and the lower anterior teeth. There is profile is definitely improved. If you drop a line from the nasal area, okay, nasolabial angle, you would understand that the lower lip prominence has definitely improved at the end of the treatment, and chin prominence is definitely reduced. So concavity of the profile was improved. A comparison of the lateral ceph shows that the before, after decompensation and post treatment shows that you got a positive overjet at the end of the treatment. That is exactly what you want in a class 3 skeletal base. The other thing that you want to see is that the lower gingiva is all good. And if you look into the parameters, if you look into the parameters and you look into the intraoral photographs, the lower anteriors were absolutely fine. Then good amount of attached gingiva, good the labial cortical bone available at the end of the day. That's the effect of buccal shell screws with optimized bracket system. It's very important that when you are doing a camouflage case of a class 3, you have to keep in mind that the lower anteriors should not undergo gingival recession. If you see something is happening like that, then you need to recall and change your treatment plan accordingly. We were lucky in this case because it is about 7 millimeters of discalization in a case where the IMPA was already reduced to start with. As you can see that the interincisor angle was huge to start with, and then the interincisor angle improved greatly at the end of the treatment. So these are very valid points that you need to know. Is it all good about buccal shell screws? Is there no failure? Nothing happens in the medical fraternity with no failures. But the amount of failure is only about 7%. As you look into the article by Chris Chang, where they have the primary failure rate, assess the primary failure rate of 1,680 extraalveolar mandibular buccal shell screws, and they found out only 7% fail. So if the buccal shell area fails, now you know that you can place it in the external oblique reach also. Basically, it is to do with you knowing the anatomy and you being bold enough to treat them, okay, with caution. Because as we told you that there are a lot of biologic boundaries, you need to respect the biologic boundaries. You need to constantly monitor the patient as to what is happening for the patient, how much amount of gingival contour, whether it's being maintained or not, whether something wrong is happening or not, whether you're getting a lot of tipping or not, whether you're inverted, you have inverted brackets or not. So all these points would go to determine the final outcome of these complicated cases, and you need to take them very precisely. So you can also go through this book, Biomechanical Foundation by Kwan-Chol Choi. It's an excellent book to read about biomechanics of mini implant systems. But if you want a comprehensive view about buccal shell bone screws or infrazygomatic bone screws, there's one article which is pretty popular among the students to know everything, almost everything about infrazygomatic and buccal shell screws, whether it be where to place them, what do you, how you want to correct the maxillary problems, so basically retreatment cases with infradiaphragmatic screws, or you want to treat cases of buccal shell bone screws. The difference in the materials as compared to the normal mini implants, almost everything that fresher needs to know about buccal shell and bone screws is comprehensively written in this article, uh, which came out in the 50th year of the Journal of Indian Orthodontic Society. Now, I hope you got a lot of clinical points out of this lecture. If you liked it, do subscribe on our YouTube channel. It's great interacting with you guys in this forum, because not every time we get a physical meet, not every time we go out lecturing, but this constant weekly update is probably that people ask from me every now and then. So this is one for you guys. If you want to follow us on Instagram, you can scan up this code and follow us in Instagram too. It's time to get back to normal life after this COVID event. Okay, but this forum is probably going to stay with us forever. We're going to keep interacting with you guys, and thank you for a patient listening on a lazy Sunday. Thank you.